happy to kind of pass it over to yourself, and I believe Professor Mason is here as well.
Yeah, I'm happy. My name is Louise Pinder. I'm actually Miss Pinder. I use my maiden name. Mrs. Pinder sounds all wrong to me because that's my mother. But anyway, I'm the senior coroner for Rutland and North Leicestershire, and Professor Mason, who you can see on the call, is the senior coroner for the city and the south of the county. Professor Mason and I have had a conversation already about what it might be that we will discuss with you all today. But I think we can be fairly fluid, and I think the fact that you've got the opportunity of speaking to both of us as the senior coroners within your county, and I think Peter Furness hopefully is joining at some point as well, is an enormous opportunity for you to ask questions and to hear what we have to say as coroners. So just so that you're all aware, I was officially appointed in August of last year. I've been a coroner since 2005. In fact, Professor Mason and I became coroners at a very similar time, but she will explain, has been a senior coroner in the city of Leicester for some considerable time now. I came from Derbyshire into Leicestershire, so the county is relatively new to me, but the job is not. I was an assistant coroner actually for many years when the court was in Loughborough, but I'm now based at County Hall in the county of Leicestershire. I wrote to all the GP practices when I was appointed, and it coincided actually, of course, with the regulation changes. So I wrote a letter of introduction to everybody and also set out my view of the regulation changes. And I sent at that time a map of the county, which of course is important to all of you to understand which area Professor Mason covers and which area I cover. So I hope you all have that. And if you don't, then please request a copy, because it will determine, of course, to which jurisdiction you refer the death. Professor Mason and I have worked very hard over the last few months to introduce, perhaps that's not the right word, because I think there was already consistency between the two jurisdictions, to maintain consistency. And it's our hope that we will continue to work in that way. So what she says very often applies to the north of the county and vice versa. But there may be some slight variations in process, and that's because we are two very separate, entirely separate jurisdictions. So you will all know that there was some very significant changes as a result of the September regulations being brought in. And I have to say that these few months on, my view about it is that things have settled down. It was really difficult for everybody to start with, getting to grips with these very significant changes with regards to referral of deaths. But my view is that things have settled down. And I have to say that some of the GPs, not all, but some, are now referring to the medical examiner and to us correctly, and we're getting really good quality referrals coming through. One of the things that I thought might be appropriate for us to start with today, because it's very topical, is the definition of attending practitioner. And there have been some recent discussions between Professor Mason, Professor Furness, and also the medical examiner leads as to what the definition of attending practitioner is. And I have to confirm again that there is no legal definition. We've had no guidance from the chief coroner in respect of the legal definition. So we are now operating and relying on guidance from the regional lead ME. And we are told, and this is a change in fact to our practice over the last few months, that if you have seen the deceased face to face or on a video call sometime during life, then you are regarded as the attending practitioner. Prior to that recent guidance coming out, we had been accepting attending practitioners as being, or appropriate attending practitioners as being, those that might have spoken to the patient on the telephone, for example. But we are told that that is no longer acceptable, and I'm sure that there'll be further discussion about this, and we are, I think, all hoping that there will be some national guidance, because it's clear to me that different coroners in different jurisdictions are being told different things. Professor Mason may have a view about this, but I certainly believe that this definition is nothing to do with us. It's certainly not something that we're imposing on practitioners or clinicians that are referring deaths, but we are told, as I say, by the lead regional ME that that is the test that should be applied. So yes, watch this space. There may be further guidance on that in due course. The one thing I would just like to talk about is the quality of the information that we as coroners are receiving. I think it's right to say that the starting point when you have a death that requires scrutiny, and all deaths now require scrutiny, the starting point always has to be the medical examiner. And going back to the point about attending practitioners, if you're not sure whether or not there is an AP, whether it's you or one of your colleagues, the starting point is to go to the ME and have a discussion with them about that, and they will be able to assist you. If there is no attending practitioner, then the coroner has to get involved. But it's often the case that there is. It's just that it's not necessarily clear as to who that is. So use your medical examiner as somebody that you can get advice from about that. But in general terms, the starting point for most of the deaths that you will deal with is your medical examiner, is to go to the medical examiner and talk to them about the death. And I think Professor Mason will talk in due course about those causes of death that perhaps are unclear rather than unknown, but go to the ME and talk to them. In terms of the referrals that are coming through to us, I have to say, reiterate what I said at the beginning, that the standard of the referrals that we're getting are improving. They're certainly much better than they were, but often we don't have enough information. Remember that we don't have access to any of the clinical records, so we are relying on you to tell us the story. We need to understand what the background is. We need you to paint the picture. It's no good you saying to us, I'm referring the death because somebody has died. I need to know the reason for the referral, why it is you think that the coroner needs to be involved. Is the cause of death genuinely unknown? Is it an industrial disease? Is there some sort of traumatic injury there? You need to tell us what has happened and correlate that, fit that in with the clinical history that you have. I also need to know that you've had a discussion with the ME, and the details of that discussion. It doesn't need to be in very great detail, but so often I'm having referrals that are coming through to me where there's no evidence or information that the GP has even spoken to the ME, and if they have, what the outcome of that is. So make sure that that information is provided to us. And it's a real bugbear for us, but and I'm sure most of you are aware that we need a GP summary attached to the referral. We try not to reject referrals that we receive, but there will be a rejection if there's no GP summary, because that's actually the only information in those early stages that we will be receiving in relation to the clinical history. So it's really important that you attach a GP summary to the referral. So it's all about attention to detail. The information that you send to us, you have to check. I know that one of the things that keeps coming up with the MEs, and if Professor Furness does join the call, he will talk to you, I'm sure, about this, but some of the feedback we've been getting from the ME service is the same, is that the information that's being received is sometimes not detailed enough and incorrect. So even things like the doctor's GMC number very often isn't correct. The details that you refer through to both the ME's office and to the coroner's office must be correct, and you must have checked it. So it's all about the quality of the information, because we can't make decisions, and we will be coming back to you if that information isn't there. Professor Mason, I don't know whether you want to come in now and talk about perhaps the unclear, unknown cause of death quandary that we and issues that are raised in respect of that. I know that we're both happy to take some questions at the end of this, but perhaps I could hand over now to you.
Thank you, Ms. Pinder. Good afternoon, everybody. As I've been introduced, I'm Professor Mason, and as Ms. Pinder said, I'm the Senior Coroner for Leicester City and South Leicestershire. I've been in post now 16 years, and so I'm sure quite many of you will actually know me or be aware of me. As Ms. Pinder's stated, is that my background goes back right to 2005, working in a number of jurisdictions. I'm also both medically and legally qualified, but my medical qualification it's not the reason I'm a coroner, it's my legal qualification that makes me the coroner. Talking now in terms of the level of certainty, that's what often people say when providing a cause of death. Doctors will often say, but I can't be certain. And in actual fact, for a doctor to sign and issue an MCCD, there is no requirement for that doctor to be certain. All there is a requirement is for the doctor to have an honest held belief based on the information that they have before them. So in other words, looking at those medical notes, discussing with colleagues if necessarily. But it is just that honest held belief. It's only when it gets to a coroner that if the coroner is making a finding in the cause of death, we need to be on a balance of probabilities. And quite honestly, if I'm going to a pathologist, then yes, I'd rather like my pathologist to be certain. But when it comes to a doctor signing the MCCD, it is simply an honest held belief. No level of certainty is required. So therefore, that is very different to saying the cause of death is unknown, when in actual fact what you're saying is, I'm not sure. I'm not sure which cause of death to put. I'm not sure how to formulate this cause of death. We accept that we are dealing with cause of death on a daily basis. We are seeing these set out correctly. We have been used to the cause of death list. There is no more, but we have been used to that. So we know exactly the wording that's acceptable. What we understand is that as GPs, you're not necessarily signing MCCDs every single day. In actual fact, I'm fully aware that you might only sign one a year. And so therefore, when you're used to writing prescriptions, giving diagnosis, the actual form itself may be daunting. But the answer isn't to simply say, oh, unknown. Because if you send that through to the coroner as unknown, now, since the statutory introduction of the ME last September, as a coroner, we have no option but to simply authorise a post-mortem examination. Gone are the days when the doctor can simply telephone us and have that chat with us to say, I'm not sure, I didn't know whether to put this cause of death or that cause of death. We can't guide that. We cannot guide you at all. So simply, if you put through unknown and where to take that, all we can do is a post-mortem. So please think to yourself, when you are putting something through to a coroner as unknown, are you really wanting this 89-year-old with a cardiac history who's evidently got ischemic heart disease, who was died in her sleep, undergoing a post-mortem examination? And I think the answer will be no. I'd like to think the answer would be no. So if it's genuinely unknown, then yes, it belongs with the coroner. But if it's because you're uncertain, unclear, not quite sure how to approach MCCD, then that's where the ME is really your phone a friend. So in the past, when it used to be a phone into the coroner's office, and chances are you would talk to the coroner or you'd talk to one of the officers, now you have the ME and the MEOs, and they are there to really support and guide. And in all honesty, although I have a medical background, most coroners don't have a medical background. And actually, it's not safe for coroners to be advising doctors in relation to cause of death, when, as Ms. Pinder said, we've got no medical notes before us, we've got no knowledge of that patient at all. And so therefore, please, if you're unsure, do make contact with the ME office in the first instance, and the ME can support you. And if really it transpires that you are unsure because actually you can't even say that an honest belief, and it seems that you're doing no more than guessing, we don't want guesswork. And the MEs will advise you to definitely, understandably, report that through to the coroner, and we will accept that. What we're also requiring is a prompt referral. So yes, we accept that if you've got that uncertainty, you're unsure, then yes, you may spend part of that day, trying to contact with the ME, discussing that with the ME or the MEO. And so therefore, there may be a few hours delay in reporting that to us. We understand that. Also, we understand that there may be a slight delay because you recognise that you're not a qualified attending practitioner as set out by Ms. Pinder, but in actual fact, an appropriate person who is back at work tomorrow, or in actual fact, Friday. That again is not an unreasonable period of time for you to say, well, actually, I can obviously see a cause of death on this. I believe it's ischemic heart disease, but I've never seen this person in life. However, my colleague, Dr. Bora, has seen this patient, he's back at work tomorrow or the day after, and I'm quite sure he can give that cause of death. That will actually save time rather than it come to me with no attending practitioner for me to send to the ME, or to send to the ME for the ME to send to me for me to then authorise the ME. If that is simply waited a matter of 24, 48 hours to sign that MCCD by the appropriate qualified attending practitioner, that can go down the ME scrutiny route without any involvement of the coroner. And to be quite frankly, to not involve the coroner when there's not a need to is obviously the best thing for all. So we want that prompt referral. So as Miss Pinder said, is that we want that prompt referral, but we don't want it rushed. We don't want promptness to lack detail. So of course we do want the accuracy, and we do want that attention to detail. And so, as you will know as doctors, in accordance with the General Medical Council, you have a duty to offer all relevant information to assist any formal inquiry. It then goes on further in the GMC, as you will know, and it specifically states with a coroner's inquiry. And so you have a duty to provide that information, even if it's not asked for, and therefore the coroner is able to rely on that information because you will have fulfilled, obviously, your duty, your professional duty that you have. What we want to say is, in regards to that prompt referral, is that if it is to the coroner, and quite rightly, because you believe that the coroner needs to know about this, but in actual fact, the coroner says, thank you for informing me about this death, and that was quite rightly so, but the duty for me to investigate is not triggered further. An example of that is if you have reported the death to me because a person has died, and in actual fact they had they was known to have a chest infection for which they were being treated, and it was a significant chest infection, and this person is in their 80s and they've got chronic obstructive pulmonary disease. So you might want to put there 1A bronchopneumonia due to 1B chronic obstructive pulmonary disease, but in part 2 it could well be that you've also put in a fall because they've had a recent fall, and that fall has also caused them a degree of immobility. But it's not caused the COPD, and it's not caused the bronchopneumonia, but it's just simply contributed. That would be quite right to refer that to the coroner. But upon making further inquiries, the coroner is also informed that that fall was at home, and in chances that fall happened because they was really quite weak and quite frail from their bronchopneumonia. With no issues or concerns from the family, the coroner's duty to investigate would not be triggered further, and we would then issue that coroner notification 1 back to you, copying in the medical examiner's office. When you get that notification back from the coroner, it's really, really important that you do promptly contact the ME. The simple reason is the ME and the ME office have not got the resources to be chasing GPs. It's also been made very clear by sort of the chief coroner, and also, but mainly importantly, as by the National Medical Examiner, that the medical examiners are not to be chasing GPs either. We know as coroners and our officers that's something we used to do, but that is very much said a no for the MEs and the ME officers because they haven't got the resources. They weren't set up to do that. And the problem is that as soon as we've signed that kind of notification to say that our duty to investigate is not triggered further, both myself and Ms. Pinder, we let the funeral directors know. And if the body is being looked after in our mortuary, then we will also let the mortuary know that the body can be released. So at that point, the funeral directors are informing the family that the coroner is no longer further involved, and it is now with the medical examiner for their scrutiny. So, that is factually correct.
Yes.
I've got somebody come off there to speak. I can hear.
We've got to wait for the doctor to come back down, but I'll check with the group.
And so with that is that, and that's actually correct for the funeral directors to tell the families that the matter is no longer with the coroner, but it's now going down the medical examiner scrutiny route. The problem is the longer that you leave than sending that referral down to the ME, the families are then raising complaints with the ME. They are blaming the MEs for delaying that process, and that is really, really unfair on the MEs and the ME officers who actually aren't large in numbers, have a lot of work to do. I would say, even though they're supposed to be properly resourced, they're under-resourced, and they're doing a fantastic job. What they don't need is unnecessary complaints. What they don't need is funeral directors phoning them to find out where it is in the system. What they don't need are family members contacting them to find out exactly why they're causing delay when it's not them. So we want the prompt referral to them. That also works the other way around, that when you have quite rightly thought this belongs down the medical examiner scrutiny route, but the ME has advised that in actual fact, no, we need to inform the coroner of this. When that happens, the medical examiner will inform us of their conversation, so we are expecting it. So please do not then sit on it. Again, we have not got the resources to do that. In actual fact, because of the ME system, it is known that our reported deaths have actually reduced, and so therefore our resources are reduced accordingly. So we don't have the time to be chasing. Now, I accept when doctors say, but we are very busy. We are treating the living. We all recognise absolutely it's important to treat the living and their patient, and obviously your patient. But what we have to remember is that, sorry, I've got somebody. Okay. What we also have to remember is that in actual fact, patients often aren't registered in silo at your practice. Very often their spouse is also registered, or other family members are registered with your practice. So in actual fact, by ensuring that you are doing prompt referrals, good quality referrals, with all the information, then in actual fact, you are also providing a service to your living patients. And that is an important service because you're providing a bereavement service. You will be ensuring that their grief is not further compounded by having to chase people and basically left in some dark hole, not knowing what's going to happen next or what they can be doing next. Finally, as you know, there has to be the portal referrals, and some GPs will say, well, that slows them down. I put this into perspective. One, the chief coroner has made it very, very clear that there has to be electronic referrals. Gone are the days when we can be taking telephone calls, when there can be email referrals. Secondly, although you say that might be time, labour intensive for yourself, as I've said at the start of this, you might be doing one MCCD a year. We're not. Myself and Miss Pinder, we're having anywhere between 1,000 and 2,000 of these to deal with. The ME office, significantly more than that, because for every one that I get, they get that one and the ones that aren't coming through to me. So please put that into perspective when you're saying that you're busy and it slows things down for you. If we was to have to do everything by hand, and I know in the ME office, because they've not got their database, they often do, it slows things significantly down for us. As Miss Pinder said, is that things are improving, and the only way that they've improved and will continue to improve if we all continue working together. One final thing that I wanted to mention, and Professor Furness, I know is on the line, may want to pick up on this. We've also been advised by the regional medical examiner, Dr. Lobo, that in actual fact, if you are referring a cause of death and say for example, a person is on anticoagulation such as warfarin, or they've had a historical surge operation, neither have caused nor contributed to the death, but you are simply including them on the MCCD for story and to make sense, and for the information, not because there's any causative or contributory role, then in actual fact, Professor Furness will raise that question, and Dr. Lobo, and Professor Furness has come onto camera now, so you can tell me if that's changed, actually says that in actual fact, there would be no reason that if the ME was quite happy with that the ME could sign that off without coroner involvement. So that's all I have to say. And with Professor Furness now coming onto camera, that might be a perfect opportunity for Professor Furness to pick up the baton, so to speak, and go forth with it. Professor Furness, thank you.
That's a bit difficult because I've just been having the most amazing series of IT problems, as well as other people demanding my attention. So, and the headset that I'm wearing isn't working at all. So you'll get interference from any noises in the room. So, but give me a recap of the last couple of minutes, and I'll try and answer any questions.
Okay, Professor, is that basically in summary is that Miss Pinder started with this, and she's briefed the doctors on the line in relation to what we now understand is the definition of attendant practitioner, and we explained that there's no legal definition, so very much on the medical definition, and that's come from the regional ME, Dr. Lobo. So she's touched on that part. We've also touched on the point as regards the accuracy of that information and the detail of that information and how important that is for us to be able to make our decisions without having to go back and forth to get further information.
Sure.
So to include as much information as is known. We've talked about the promptness of that referral, both to yourself and to us, to avoid the unnecessary complaints coming in from the bereaved when they feel that it's being delayed by the coroner or it's being delayed by the ME. In actual fact, it's not. It's because we don't know about the referral yet and we've not got the resources to chase. I've also talked about the certainty, and that certainty is not required. It's the honest held belief that's simply required, not certainty. And there's a big difference between genuinely unknown, for example, a 45-year-old with no medical history who is suddenly found deceased, absolutely unknown, compared to a 84-year-old who you're a little bit unsure what cause of death to give, or how to formulate the MCCD. We've said there's a difference between unknown, which if that comes through to the coroner, it means a post-mortem, as to being needing a little bit of a help, a little bit of a guidance, how to complete the MCCD. And then we've said that we recognise the importance of treating the living, but in actual fact, just one moment, Professor. But in actual fact, very often the deceased aren't registered in silo with the practice. They have spouse or other family members. So in actual fact, by dealing promptly, you're also treating the living with the bereavement service. And then finally, I finish in this point that I said you may wish to come in on, is that we've recently received guidance from the regional medical examiner, Dr. Lobo, that if warfarin or an operation is simply going on the MCCD for information purposes only, and it's not causative or contributory to the death, then in actual fact that can go through with medical examiner scrutiny and sign off without needing the coroner to sign it off as well. And then I also said that, and I said also the cause of death list as we knew has now gone. It's no more. So that's a very quick recap for yourself, Professor Furness, and those online.
Okay, thank you. Well, that sounds like a recap of what I actually heard you saying yesterday evening, and agreed with everything you said then. But the only points I would possibly add to and clarify is that the definition of attended, at the moment we are working with that provided by Dr. Lobo, the regional medical examiner. As you know, that doesn't really tie in very closely with what we were told by his boss, the national medical examiner, a few weeks ago. So I have last night sent another message directly to Alan Fletcher, the national medical examiner, saying, can we have clarification of this? Haven't heard a reply yet. In the interim, we have to play safe and basically go with what Dr. Lobo says. So attended equals face-to-face or video consultation, not telephone calls. As far as the warfarin business, I think that ties in with the way that we have been working recently after discussions with you, whereby as long as the anticoagulation was appropriately given and clinically justified, and there's nothing went dramatically wrong, if it just sort of may have contributed a bit in part two, shall we say, and there's effectively nothing for the coroner to investigate because it's a recognized risk of any warfarin therapy, then we can put that on the death certificate. We can mention it, but we don't need to refer to you. And because the registry office is basically believing what the medical examiner says and not checking out the causes of death like they used to, that should get through okay. Right, have I caught up?
Yes.
Good, thank you. Are we waiting for other questions from the GPs assembled?
No, I think it's possibly from you now, Professor Furness, in relation that we were giving it from the perspective of the coroners, and so whether you want to bring anything more from the perspective of the ME and the MEO, please.
Well, as I say, I agree with what you said last night, so I don't think I'm going to add anything to that, apart from the medical examiner.
Sorry, Professor, this is I believe this is a different group to last night, though. This is a completely different group.
Yeah, but I'm assuming that you said something similar, because I know you're a consistent lady. Right. From the medical examiner's perspective, the biggest problem we have is getting hold of GPs, and we know that GPs don't want to be interrupted halfway through talking to a patient. We have put out repeated pleas to have mobile phone numbers, not that we necessarily expect you to answer them while you're talking to a patient, but that is the easiest way for us to get to send either leave a voicemail or send a WhatsApp or text message or whatever, saying, we need to discuss this case, please ring us back. Even the practice bypass lines are problematic. I've just spent 5 minutes listening to Muzak on a GP's bypass line. So okay, use that if you must, but mobile phones are much better. And the public-facing practice phone numbers that have long lists of options followed by a you're in a call queue really isn't going to be a way that we can work. So that's my current main message to GPs. And oh, incidentally, we've also, we had a backlog over Christmas and the New Year that has now gone. So no need to tell your bereaved relatives that the medical examiners will take an inordinate amount of time. We're getting most cases looked at least provisionally within a day or so.
Sorry, Professor, I just want to pick up on a point there, and I know it's something I discussed with Miss Pinder yesterday, and it falls on the back of that and that prompt referral. What people might not realise is that the longer that deaths are referred to the coroner, then the longer that these the deceased are actually kept in storage. So therefore, sometimes if that death, and we've had this, is not an exaggeration, we've had that where the death has not been referred to the coroner, the ME for 14 days.
Yeah.
The ME has then carried out their scrutiny, and as Professor Furness very openly, very candidly, they said that they had a backlog over the winter. And I'm sure Professor won't mind me saying that unless systems change, what happened this winter will happen next winter as well. And so suddenly the turnaround for an ME office going from 24, 48 hours can easily go up to 7 days. In our winter period, that would not be unreasonable. If you have not reported that death for 14 days and it takes 7 days to get through the ME system, that's 21 days before it's coming to a coroner. If a post-mortem has then been carried out, that body has already started to decompose. Even if it's been kept in a mortuary fridge, it's still not in the same condition as when died 21 days ago. Equally, we're quite lucky in Leicester. If I instruct a post-mortem examination, same as Miss Pinder, very often that post-mortem examination will take place in 24, 48 hours. But again, with the winter pressures, that is not always the case. And we can be getting very, very close, therefore, then 28 days before that post-mortem examination is being carried out. As Professor Furness will know, and obviously support me on this, is that by 28 days, the Health and Tissue Act, the HTA, actually states that a body should be going into a freezer at 28 days if it's still in the mortuary. The truth of it is our freezers are not kept there for delayed reporting. They are kept there for suspicious deaths and baby children deaths. So therefore, we could not guarantee getting these people into a freezer. So therefore, we are not treating them with the dignity and respect that they deserve, and also what the bereaved actually expect. So again, it just shows the consequences of delays in referrals. So again, that's our plea. Why not to?
Yep, agreed.
But Peter can't actually look at them anyway, though, can he?
Yeah, I think can I just dive in there and just say that the reason for the delays, I think, are perhaps multifaceted, but one of the things that we have found is that there's a misunderstanding with a number of GPs, and Professor Mason, you might be able to help me with this, that if they get a information from the East Midlands Ambulance Service that a death has occurred, then GPs sometimes are sitting on that and not doing anything with it. The GP is under a duty to contact the medical examiner and or the coroner, depending on the circumstances of the death, and make sure that they know about that, because Professor Mason will tell you, as will Professor Furness, we don't know. We don't know what we don't know. There's nothing that we can do until we get a referral. And sometimes what happens is that we're getting phone calls from families. We know nothing about the deceased. We know nothing about the family, and they're telling us, our loved one has died. We don't know what's happening with this. And my coroner's officers are then having to do chasing up, finding out what the status of the investigation is. And on some occasions, it is sitting still with the general practitioner. So that's causing some difficulties as well. I think it's right to say, isn't it, that if the GP practice hears about a death, they need to do something with that. They need to contact somebody and make sure that either the ME or the coroner knows. But the starting point is always the ME, isn't it?
And the ME only has a duty to act when a doctor has referred a death to the medical examiner service. I imagine the coroner's office is similar, except that
exactly
you get
the same
referrals from several sources. If we get a notification from the coroner or from the ambulance service that someone has died, we will, in practice, try and contact the GP to say, why haven't we had a referral? If we then hit the public facing practice switchboard and can't get through, I'm afraid we've got other work backing up, because our duty to do something only starts when a doctor informs us of a death.
Is now an appropriate time just to interject? I've got a couple of hands up, so if that's okay, I'll Dr. Spall.
Hi, thanks. About the ambulance service, be really helpful if they could stop telling practices that they will be referring the case to the coroner and that there's no action for the practice. We've had that recently. My practice manager took the call. I've listened to the transcript. The paramedic is saying, we're doing this, there's nothing for you to do. Actually, because of our protocol, we caught that and we said, no, we are referring it. We need to ignore that. But it's really tricky when ambulance services are actually saying that to our reception staff who take the calls. In this case, it was our practice manager, so she knew to do something different, but not every receptionist is going to know that. And it's really confusing for people. And it would be really helpful if they didn't do that.
Dr. Spall, I have to say thank you for bringing that to the attention. Is that in my area?
We're New Verdon, so we're Miss Pinder's area.
Miss Pinder's.
Yeah.
And I'm going to say, I can't speak for Miss Pinder, and of course, with it not being my area, I'm not entitled to those details. But I'm quite sure if that information was passed to Miss Pinder, either on her own or jointly, we can raise that certainly with Miss Jevons at the East Midlands Ambulance Service. And this is what we need. We need the evidence, because you can imagine is if we just simply say, oh, we've been told, we can easily be that can be rebutted. And so therefore, if you can give us the evidence of that, obviously I'm not entitled to that evidence because obviously it's not referred through to me, so I have no jurisdiction for that. But I would certainly support Miss Pinder in writing to to EMAS.
I have, Dr. Spall, I have heard of this happening before, actually. So it's not new to me. I'm not sure it was your practice. It may be another, but this definitely had been raised previously with me. And I have had a meeting with Sue Jevons at EMAS to discuss this. And I think it might be some rogue paramedics rather than their process and protocol. But I agree entirely with what Professor Mason's saying. If you wouldn't mind contacting me via the coroner's office here in North Leicester, Leicestershire, and we'll contact EMAS again and say this mustn't happen, because I agree with you, it creates all sorts of confusion, doesn't it? And thank you for your practice manager for picking that up and referring the death through in any way, because we wouldn't have known about it otherwise.
No,
so I'm grateful for that.
We've had a couple of instances of this, and one of them unfortunately last year led to a delay and a very unpleasant delay for the family. So we changed our processes, so we knew, but it's just very confusing. But yeah, I've got the transcript, so I can send it over to you.
That's really helpful. Thank you, Doctor.
Thank you.
Well,
thank you. We've now got Dr. Ballara.
What's that saying? What are you saying?
Hello, hi. Thank you very much for all of you being there and telling us. I work in Burbage, and I just need to understand the process when we encounter an unexpected death. So I'll give you an example and just guide me, because I don't know how to go about this. So I was on call yesterday. We had a phone call about 11 o'clock in the morning stating that a 66-year-old gentleman known to me, who doesn't frequent the practice, and he was found dead. So essentially what happened was, he normally his background briefly is that he hasn't got any physical health conditions. He suffers from anxiety and depression, and he lives on his own, and he's not working. He has not worked for several years. He relies mainly on his sister. He goes for the weekend for meals, and then on he's supposed to go on Monday to see his sister. He doesn't turn up, so the sister got worried and turns up to his house. And then this was in the evening. It was in the out of hours. So this is another context, really, when in hours and out of hours. Essentially, she found him dead, and there was nothing suspicious around there. So the question is, when do you raise suspicion? When do you call the police? So she rang the police saying he was fine. He was supposed to come to my house. He hasn't turned up, and he was found dead. So next day, I get a call. He's saying that from the sister saying that he's in one of the funeral directors' home. The advanced doctor or clinician, I don't know whether he's a doctor or not, just asked the patient, funeral director to move the body. So, and I did the coroner's referral on the portal, which can take quite a long time. And also I did a referral on the ME system as well yesterday, because I didn't want any delay, because the family are expecting normal, cause for death. I couldn't hand on heart tell the cause of death because he was actually fine. So in the what I need to know to understand the process is, in the out of hours, say it is Saturday or Sunday, if somebody passes away, who does the referral to the coroner, and when does the police get involved? When does it come to the practice? As Kerry said, we've had one problem similar to that, where the paramedic said, oh, you don't have to do anything, and there was delay, and then we had to do a coroner's referral. There was not suspicious death. So, sorry, I've got a lot of questions because I was dealing with it yesterday, and it took me a long time to explain to the family.
Could I perhaps address that and then pass it back to the coroners who actually have the authority? Because in that sort of situation, I think probably nowadays your first reaction is have a discussion with a medical examiner, and we do have medical examiners available to at least some extent out of hours. There are numbers circulated, but if all else fails, you can contact us through the switchboard of the University Hospitals Leicester. If we agree that you really can't offer a cause of death, then we will advise the coroners that that's a reasonable position. In fact, I've just had an interesting case this morning, which touches on that, where an elderly man was found, died suddenly and somewhat unexpectedly. He had a doctor-phobia and had almost nothing on his medical record at all to explain what had happened. But he had been seen the week earlier with a history of severe abdominal pain and constipation, sounding like intestinal obstruction, and completely refused the suggestion of going to the emergency department. Next day, found dead. Now, in that sort of situation, I would say, and I think this is what the coroners would like me to say, that if everyone concerned is convinced that this is a natural cause of death, then to the best of your knowledge and belief, you could have put 1A spontaneous intestinal obstruction, which is an acceptable cause of death. In this particular case, there was not just uncertainty as to the cause of death, but we had a report from the police saying that they had found some suspicious circumstances at the place of death, whereupon we just say, well, we don't know what they are and it's not our job to evaluate them. Please inform the coroner. So it's one for discussion, but if everyone is convinced that this is a natural cause of death, then you have to have a pretty flawless medical record for it to be impossible to suggest a cause of death to the best of your knowledge and belief.
Okay.
Dr. Balaram, I think there are a number of different issues here, aren't there, for you?
Yes.
And I'm grateful for what Peter Furness has said. I think perhaps one of the other issues is the fact that and Professor Mason and I have had many discussions with the police and with the ambulance service, yes, and with GPs about this, is who's doing what. And I'll be honest, yes, with you, there is certainly a bit of a standoff when it comes to verifying deaths. I mean, you will be aware that the East Midlands Ambulance Service and the police are both saying, well, we're not going to come out if the individual is obviously deceased. I mean, the police are sort of attending as an absolute last resort so that families aren't left in the community with their loved ones deceased in the house where others won't attend and verify. So this is an ongoing issue, and I think that the discussions that we have had, and I know Dr. Ingrams has been involved in this, is that there isn't any one there isn't one size fits all. You know, it's very much case specific. But actually, if it is likely to be a natural cause of death, that there are unlikely to be suspicious circumstances, then the GP should be going to verify the death. I agree. In this instance, you're talking about it was out of hours, so it would have been DHU or the likes who were going out. It's not straightforward, I think, is the answer, which I'm not sure is very helpful to you. And that different scenarios, or even very similar scenarios, we are seeing that there are different people involved and making different decisions in relation to similar circumstances. So I don't think it is straightforward. But the bottom line is, from a coroner's perspective, if there are no suspicious circumstances, whether or not that's reported to us by the GP who turns up to verify the death, or whether that's the police, if the cause of death is likely to be unnatural, likely to be natural, and the cause of death, even if it's unclear, is likely to be known, then it's not a matter for the coroner. It does go to the medical examiner, and then there's a discussion between you and the medical examiner about how to take that forward. So I hope that helps, but I do understand the frustration for everybody involved, actually. And as I say, we're having conversations with the East Midlands Ambulance Service, with the police, with GPs, about who actually is going to take responsibility for some of these deaths. And it's not clear, but it's certainly not going to be the coroner, because if it's a natural cause of death, it's not a matter for us. Yeah. And that is very clear now. There's that distinction between medical certification and judicial certification. If it's natural, it's not coming to the coroner.
Yeah, so essentially what you're saying, if it's a suspicious death, then of course the police will get involved, because it's suspicious, of course, and they will take things from there. Am I right? And if it's not suspicious and somebody's unexpected, then I'm supposed to ring Professor Furness's team to clarify how to go about this. Is that right?
Yeah.
Yeah.
And the ADVAS service should be ringing you as well, Professor Furness team. Is that correct? Can we communicate with the?
There's not a lot of point
No.
a doctor ringing me if they're not in a position to complete a certificate giving the cause of death.
Yeah, they won't be able to. But
no, because they haven't seen the patient during life if it's out of hours.
So in this gentleman where I encountered yesterday, he's 66. He's got no physical ailments I know of. And I couldn't give him a cause of death, really. So he needs possibly post-mortem, but that discussion to be had with the family, and then with us, and then with the coroners, really, to come to some sort of joint conclusion, really. So is that right?
No, it's still the medical examiner. As Professor Mason said earlier, the coroners now can't get involved in any discussions about the cause of death. If it's unexpected, but the cause of death is natural, then it's a matter for you to discuss with the medical examiner.
Okay.
And if you discuss it with a medical examiner, and as Professor Mason said, it's someone with essentially no medical record who's dropped down suddenly, or if there's something like maybe they've got a history of mental health problems and they're on antidepressants, that it's a case-by-case basis. But we've had quite a few where GPs have discussed deaths with me, and I've agreed that the cause is so unknown that it might be unnatural. So then we send it off to the coroner, and they seem to accept those decisions.
Okay. So thank you very much. I know it's not much clarity with the EMAS.
Yeah, I think the thing is, yes, I think between us all, we've tried to make this as streamlined as possible as we can for GPs. So as opposed to GPs thinking, oh, I don't know, is this one for the MEs? Oh, is this one for the coroners? We don't know. So, I'm the first to admit, in actual fact, by taking this as streamlined approach as possible, I actually often puts more work on the ME service. That's not what we want to do, but it's very rare that we get, as a coroner, an absolutely obvious, unknown, no medical history incorrectly reported to us. So I have to say that, yes, if you looked, and the example I gave before, is a 43-year-old male, no medical history, none, not attended at all, for no reason. Yes, you might have seen in life for a chest infection when they were 18. But other than that, absolutely nothing to go on, or an ingrowing toenail, but nothing at all to go on. They're not on any medication at all. No history of alcohol, no history of drugs, and you're saying, I am really at a loss. And if you spoke to Professor Finesse, he'd say, absolutely, you may as well just pass me a blank medical sheet. But actually, they are few and far between. They really, really are. And sometimes, even on that, even when if they do go down, sometimes with that joint discussion, more information can actually come out. But I'll leave Professor. But I know that by doing that and saying, look, because what it is, the truth why we've had to take that stance is because a lot of GPs will say it's unknown. And actually, what we know historically, it's not that it's unknown. What they mean is we don't know how to complete the MCD. I don't know which cause of death to give. I don't know what I can put and what I can't put. I need some advice. And that is the problem that we have, that as Miss Spin said, we can no longer advise. That's what last September made those clear rules, that advice is the ME.
Is
it better to pick up the phone, or
death genuinely is unknown cause or not is inevitably a judgment. And the thing about medical examiners is that we work very closely with the coroners in the area. Most GPs interact with coroners rarely. If we start getting that judgment wrong, the coroners will have a discussion with us.
Yes.
And we'll probably modify what we're doing. But that's how it works. And that's why the medical examiners are in a position to advise on whether unknown cause is reasonable or not.
Yes, okay. So is it better to pick up the phone if you're unsure, Professor? Just to clarify that, Professor Furness, I meant.
Yeah, pick up the phone to speak to a medical examiner.
Yeah.
If you're in doubt, certainly. It's often easier for us if we have some email notification before that, simply because it then allows me to have a quick look at the medical record.
Yeah.
And I can give a more informed discussion. But,
you meant the PRISM
whether,
referral. You meant the referral which we did. We do the PRISM referral.
Whether it's a referral using the PRISM form or an email to the medical examiner's office, as long as you give us the information that allow us to get the information and to get back to you, we can then take it from there.
Oh, that's very useful. So thank you. Sorry to hog the.
No, thank you, Dr. Balaram. I'm just going to kind of move it on, if that's all right, because I have got another question within the chat, which I could just pose to you. Could you please provide some examples of an unexpected, unclear, unknown cause of death and whether an autopsy is needed?
Examples? Well, I just gave one of one where someone had no medical record but symptoms just before death, highly suspicious of intestinal obstruction, and my suggestion there would have been 1A, spontaneous intestinal obstruction, were it not for the other circumstances that switched it into the other lane. Do the coroners have any examples of cases where you think, well, that was a waste of time? Why do we investigate that one?
Another one that might be unclear is one where the doctor believes it's chronic obstructive pulmonary disease. That goes down to the ME scrutiny. Upon ME scrutiny, the ME then speaks with the family, and the family then say, oh, actually, whilst he was at work, he was exposed to asbestos. Suddenly, it's unclear whether it truly is simply chronic obstructive pulmonary disease due to his smoking, or whether it really was due to asbestos, of which case Professor Furness would quite right to say, this is now a little unclear, and we need to pass this to the coroner. Unexpected, we have to be very careful, because it's not just a case if it's unexpected. Is it unexpected and is it unexplained? I think only those wielding a knife or a gun that causes a death can say that person's death is expected. So sometimes people might say, oh, well, they're on end of life care, but they weren't expected to die today. That does not make the death unexpected.
Yes, I find expected and unexpected very difficult, because it depends where you measure it from. My death is expected, but not today, I hope.
Thank you
Yeah,
all.
I've got nothing to add really in relation to that, except to just to reiterate that, of course, that it's the unknown cause of death where an autopsy is required, and that's the only circumstances in which we would have an autopsy. So the unexpected and the unclear bit, that's the conversation with the ME, and if it remains unclear following a conversation with an ME, then it becomes unknown, and we will therefore have to authorize a post-mortem examination.
In that context, if that makes anyone feel uncomfortable, it may be worth pointing out that the UK, I think, still has one of the highest medical legal investigation of death rates in the world. Certainly used to be the case.
You've all kindly kind of given the kind of an update on the conference on where you are and your positions and that kind of thing. Professor Furness, did you have anything more to add in relation to the ME service and how it's kind of developed since September?
I think, well, we have struggled, yes. We are having discussions about what we can do to improve matters. Unseen to most people, I'm concerned that we are not actually looking as hard as we used to for problems with care. We don't have the time at the moment to do the statistical analysis that ought to be being done to look for trends and identify outliers. But we're doing our best, and that's down to, as usual with the NHS, that's down to the resources allocated by those who allocate resources. Hang on. Oh, Rebecca Broughton has just joined me. Looking like someone who has something to say on this subject.
I think the thing that may get noticed from the 1st of April, we are thinking that we will be more likely to feedback or ask for amendments to be made to the certificates, because obviously the aim of the whole ME process was not only just around giving the bereaved a voice and also to look for potential problems in care, but was to try and improve the death certification in terms of causes of death so that we as a country can see what people are dying of. We have got some discussions to have internally about trying to make sure we're consistent as a service about our understanding of what constitutes frailty, what constitutes old age, that type of thing. But we have been letting a lot of certificates go where we are not sure that that is the best certificate, for want of a better phrase. But we do think that we will maybe start to try and not just feedback, but actually ask for amended certificates. Now, I know some GPs might think that we've already been picky. Believe me, we have not.
Thank you, Rebecca.
Thank you. I don't have any other hands up. Does anybody want to ask any more questions whilst we've got Professor Furness and Professor Mason and Miss Pinder with us? Oh.
I do hope that means everyone's happy rather than gone to sleep.
That's great. I think it's just a useful opportunity to obviously kind of, and I know it was kind of rare to be able to get you all three together, but to kind of build those kind of relationships with our kind of members, to kind of hear about kind of obviously kind of themes, and an opportunity to kind of share kind of information has kind of probably hopefully been really useful for our members. And I know that obviously Dr. Ingram's has a lot of engagement with you in relation to developments and that, and he sends his apologies to not being here today. But if no more questions, I really appreciate kind of everybody's time, and I'll kind of draw this meeting to a close.
Okay, could I just add that I've splashed my email address and telephone number about quite liberally, so if anyone thinks of further questions later, send me a message and I'll put my email address in the chat box as well, but as we finish. Okay.
And I'm quite sure if Professor Furness receives something that's from myself and Miss Pinder, he'll forward that on to us and we will address it accordingly.
Thank you. Thank you all.
Thank you, everyone.
Thank you all. Bye.
Bye-bye. Bye-bye.
How many GPs were at that one?